This conference will now be recorded.
So welcome everybody. My bad, it's Rick Davis. I forgot to start this at the beginning. We're about 20 minutes in. We're talking to Mark Finn about his difficult case to treat and AMG 509. Special thanks to all of our sponsors who are Bayer, Pfizer, Janssen, Myriad, Myovant, Blue Earth Diagnostics, Foundation Medicine, and Telix. I think that's everybody. And
Good
if I
job.
missed it, and if I missed anybody, if I missed any sponsors, I'm sorry, sponsors. So let's get back to the conversation. And Mark, did you want to respond to Dennis?
No, I was going to ask, what was the name of the hotel chain you said had some sort of.
That was the wait a minute, Extended Stay America
Oh, okay.
Hotels.
Right.
Okay. Thank you.
Yeah, extended stay has a deal with ACS, and you get very good rates at all the extended stay uh, hotels.
Okay.
So, okay, now, Mr. Yancey, is there anything you would like to know about AMG 509 or anything similar?
I don't know anything about it other than what I've just heard here now. That's about all my knowledge has. So right now, I'm sticking with. I'm going to chemo this week, carbo and paclitaxel, and then we'll do scans early August. Where we're at.
And when are you leaving on your bike trip?
I'll leave July 8th. It's going to be Plan B now. We're not on two wheels anymore, and be back towards the end of July, and that's why we're pushing scans out till early August when I get back.
Okay. So should we be tying cans to the back of whatever you are riding on?
It's going
When you
out though,
leave?
unfortunately.
Okay. Well, yeah, I mean,
July 8th.
you know, I think that the issue that this whole conversation raises is what do you do when you've been through Pluvicto and you've been through the docetaxel and you've been through all the regulars, how do you identify that trial that um, is one likely to be a significant trial and two to be tolerable? And most of these the trials we're talking about right now, some of these are still phase two trials. So, phase two, we're testing tolerability. That's what phase two is doing. And they're tough trials, and they can be tough trials. And do we know that they're good trials? And I think if we find trials that we know seem to work, I mean, if Mark does decide to go into this AMG 509 and Len's absolutely right. I mean, Herb, go rest his soul, and Len were excited about this back in the day. Then we can start turning other people onto it, especially a trial like this AMG 509, which I think is available in 29 locations around the United States. I think, or it might be 29 in total. I can't remember, but it is available in quite a few different places. Not all of them the quality of Memorial Sloan Kettering, which is, I think, a big issue. I'm not sure I'd want to do this trial in a local community-based practice. I mean, that's again something that you've got to take into account. But yeah, I mean, sourcing the trials is a big deal. Um, I want to move on at this point and talk to George Struck.
Oh, one thing,
And
Len, Rick, before you move on, one thing that I've learned through this process, I also wanted to share with the group is kind of twofold. Number one, there's great resources and people like Rick and Len, and there's some other people I've talked to. I talked to Mike Yancey. He has some great ideas to share with me. Um, but unfortunately, we don't have a mechanism right now where, for instance, I could put in the key parts of my case, and then they could say, okay, here's the 10 trials you really should look at. Here's the immuno trials.
right,
Here's the chemo trials, and so on. So it's really tough. You can do some stuff with the clinicaltrials.gov, but it requires a lot of courage and perseverance. The other choice is there's this FEN trials site, and that's helpful too, but you're in the same thing. In my situation, I might I mean, if it's only all that I can consider is a phase 1 or a phase 1/2, I'll consider those. But really, I'd really like to get more into a phase 2 kind of trial. Phase 3, well, I don't want to be in a placebo trial. So I do think one of the things also I learned from this is for any of you that are either on or considering Pluvicto, depending upon how severe your case is, but if it's an advanced disease, which I guess if it wasn't, you wouldn't be on this phone call. You really should be looking at your clinical trials now, because my recommendation is you do these things in parallel and don't do them sequentially. I've sort of done them sequentially, so that I figured out that Pluvicto wasn't working, so now let's look at clinical trials. I wish I already knew what I was willing and not willing to do and had that decision today, and I'm still looking at that. So I think the earlier you get into it, and if it turns out Pluvicto turns out to be wonderful for you, then all you've done is I don't think you've wasted any time. It just means you have to put it away and you have to come back and do it again sometime in the future. But if Pluvicto doesn't work particularly well, then you're prepared for the clinical trial step.
Yeah,
Okay, thanks, Rick.
No, I think that's very, very solid advice. Dr. Bob, you wanted a comment, I think, on this trials issue.
Yeah, just one other potential source for looking at trials is Cancer Commons. Again, you have to send them your info, but they have PhDs who will look at and potentially help guide
Yeah,
you.
yeah, they do, but we've never had I mean, I know you've used them. We haven't had a lot of success in the prostate cancer area with them, and the sort of success we have had is what I call chasing your tail up a spiral staircase of an ivory tower. And I think that's a big issue with Cancer Commons, and a big issue with the whole concept of Cancer Commons. I mean, Brad Power, as some of you know, his forum, they got together to try and emulate a Cancer Commons type of situation. It's been very hard to do. And what we often see is they come up with some great ideas, but unfortunately they only work on mice. And here at ANCAN, we've very much taken the attitude that we want to wait till the science gets a little bit further. We're not saying it's bad science, but we are saying it's unproven science. And to start making decisions on how mice react, we don't think that makes a lot of sense. And so much of what gets discussed at Cancer Commons and in the power things, I don't mean to offend anybody here, but we feel it's esoteric, and I think that's the issue. And Mark makes a really, really good point, and it's been said for years. There is no solid way to really track down the right trials. There are services that are supposed to be available. I think there are services that on Brad Power's group that people have used, but I honestly don't know what they produce. I don't know what they produce. I mean, when you've got a Herb, God rest his soul, or a Dr. John or a Len who's looking through the trials with the sensitivity of a patient, then we can find certain things that might look appealing or might not look appealing, and we do bring them up in this forum. But it's very ad hoc, and that there's no systemic way. That's
the other thing I mentioned, Rick, is that Rick suggested, and I tried it, the Inspire website, which you put some information in. It's supposed to have some AI can come back to you. It did, but it was sort of like the AI came back and said, "Mark, you have cancer. You should consider treatment." So it was so generic and so high level that, at least in my case, now I think for people who are newly diagnosed and they're trying to kind of get through the shock and trying to sort this out, it may be a great resource to start identifying things that they should know along the way. So there are some other things out there, but I'll tell you, it's disappointing how little there is available in resources to kind of help you
Yeah.
through this.
So we have to move on, and we're going to move on and talk to George Struck, introduce him to the group, and talk to Nazir also in the context of talking to George Struck. George, we have another gentleman who lives in Niagara Falls, Ontario, who is trying to enter into a Pluvicto trial in Ontario or Quebec, most likely Quebec, because the Ontario site hasn't opened yet. And in the course of that discussion on Pluvicto, I want to get into the whole question of durability of Pluvicto, which is something Mark touched on, and it's something I've been looking at in the last couple of days. So George, welcome to the group. I know you come through Neil Sundstrom, who I've been working with personally since about 2013, and I get to meet him in person finally later this year. I know a little bit about your background, but other people don't. So I'm going to ask you a few questions, if that's okay by you.
Okay.
And we'll talk a little bit. And there's a lot of stuff I don't know. So, how old are you?
86.
86. That's fantastic because Nazir is 87. So Nazir, there's hope for you to get into this trial yet. I'm so happy to hear that. So, and I've been working with Nazir since about 2016 or 15 or 16, by the way, George. And you live in Vancouver, British Columbia, is that right?
Oh, I live in Whistler at the ski area, which is about 7-8 miles north of Vancouver.
Okay, so you live in Whistler. Okay. And what year were you first diagnosed?
Well, 18 months ago.
Oh, wow. 18 months ago. So that's 2020, like the
January
very end
22.
of 21.
January of 22.
Wow. Oh my gosh. How did you get that far along? Anyway,
Well,
and when you were diagnosed, what was your Gleason score and your PSA level?
well, the whole thing started with my right eye was bulging out, and I couldn't figure out what was wrong. So I went to the medical center and they did a scan, and they said, "Oh, you've got a tumor growing behind your eye." And I thought, well, that's not good. And after some tests, they said, well, we think you have prostate cancer, and we think that tumor behind your eye is caused by the prostate cancer. So we're going to treat you for prostate cancer. And they put me on Zoladex every 90 days and apalutamide.
Okay,
And
so
the
let me stop you right there. Did they ever biopsy your prostate?
no.
No.
Now, when they first discovered it, my PSA was 1200. And
Okay, so I'm going to ask you that. So, yeah. And Margie, you're very welcome to show yourself and come right in.
Hello, everyone. I'm just here in the back
Hello,
taking
Margie.
notes.
We love
well,
having care partners in this group. So
Okay.
you're totally you're 100% welcome.
Thank you. Happy to be here. I want to learn lots more, so I'm listening in the background.
Okay, so
when
your
I was
PSA was
83, when I was
yeah.
83 and 84, and I'd go in for my physicals, why I would ask the doctor, "What about a PSA test?" And they said, "No, we don't bother with people your age because all the old guys get some prostate cancer. It's slow growing and it doesn't kill you." And they checked my prostate and they said, "Oh, your prostate is small and it's not enlarged and there's no lumps on it, so you're good to go." Well, guess what? Now I've got it.
And you have no pain.
So I mean, I can see why they would not. I can see why they would not biopsy you. But the problem that we see here with that is that they've never done any cancer, they've probably never done any genomics on you. They've never taken a look to see what sort of mutations you might have. Is that right?
Yes. Well, I did have a test done down in Eisenhower Hospital down in California to see if my DNA is susceptible to cancer because I have a younger brother. And the report came back, no, you're not susceptible to cancer, but I still got it.
Okay, but that's what's called a germline test. That's to see if you inherited anything from your parents. And in the United States, for somebody with your situation, it's required or guided. The guidelines say that you should get a test of the tumor to see if there's anything particular in that tumor that makes it suitable for treatments. And we strongly recommend that. And in fact, Nazir has done that. And I was just talking to Nazir, and I'll put you and Nazir in touch subsequently. But Nazir has done that, and you can do it through Foundation Medicine in Canada. And we think it's really, really important. And where are you being treated now?
In Vancouver.
At the Vancouver Prostate Center?
Yeah, the BC Cancer.
Right. And is Kim Chi your doctor?
No, right now, since they're treating me for cancer, it's Dr. Nappi, Nappi.
Okay. Well, Dr. Kim Chi is a really good doc who's at Vancouver. He's probably the best genitourinary medical oncologist in Canada, in my view. But that's my personal view. And
I
he
started out
understands.
with Dr. Gleave.
Who's
Yeah.
UBC?
Yeah, I've heard of Gleave too, but Kim Chi is really, really good. And we would, he for sure would be understand the need for a genomics. And I think you should be talking to Vancouver about your genomics and getting genomic tested. They can do it with a blood test. They can absolutely do this with a blood test and send it to Foundation Medicine or whoever they choose. But I feel without doing that, even though you've been accepted to the Pluvicto trial, which is kind of a spoiler, guys, because I know that part, and that's why we've got George in here right now, because he wants to hear from you what to expect with Pluvicto. But I think
I should jump in here right now and tell you, the drug trial, they do not talk about Pluvicto up here. The trial nurse doesn't even know the name Pluvicto. She calls it lutetious or LU177. So
right. So let me just clarify that for you, Margie.
okay,
What they're trialing is lutetium 177,
yeah,
PSMA 617. Okay,
yes,
that's a bit of a mouthful, and that drug has been now approved in the United States and is sold under the trade name of Pluvicto.
okay,
Okay, so when we say Pluvicto, it's just to save us saying lutetium 177, PSMA 617 every time.
okay,
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 it's the same. It's the very same thing.
okay.
Now, did they ever do scans on you, and where else is the cancer, George?
Oh, well, I've had all kinds of bone scans and the PET scans, and the cancer spread to my bones.
All over.
I've got it in my head and my backbone and my pelvis and my thigh and my ribs.
Okay, and have you done chemotherapy?
No.
Okay. So again, this is unusual, guys, because this trial doesn't require chemotherapy first. You
No.
should understand that, George, that in the United States, lutetium is only available right now after you've done chemotherapy.
Yeah.
Well, they have made this clear from the beginning during this trial that there'll be a lot of blood tests, a lot of scans happening, and they track the results. And if the results from the Pluvicto are not good, then they're going to switch me over to the chemo.
Right. So, and what we've seen to date, depending on how well it's advanced, and this is just our anecdotal experience, is that the gents who have done chemo first may do a little bit better if they're well advanced. If they're well advanced. If they're not advanced, I don't think it matters so much. But let's get to, I think, what you want to hear, which is, and I know Nazir would also like to hear this. And Nazir, I will come to you right after George to talk about your details. But guys who have been on Pluvicto, what advice do you have for George and for Margie, given they're both about to start to go through this? Who'd like to start? No one? Do I have to pick on someone?
Well, I'm not quite sure what you're looking for, Rick, but I just say that, I went through 5 trials, um, uh, 5 infusions for Pluvicto. It's an inconvenience because you have to isolate for about a week from your spouse for 2 or 3 days, and then from other people because you are radioactive. You're putting off radiation. You want to be very careful about when you're getting the treatment. I used ice chips, but you want to basically try to reduce blood circulation to your salivary glands because that will help you as far as have less of an impact from loss of taste and also less impact from dry mouth. I think my wife would say that I had some increased fatigue during it, but that was beside that it was pretty manageable for me.
Thank you, Mark.
Didn't work, but it was pretty manageable.
Let me ask a couple of others, and then I'll come back to you, George, so you can ask them questions. Mike Yancey, you want to add anything about advice for Pluvicto?
Of course, in my case, Pluvicto was working very well for my cancer. It was putting out PSMA, but unfortunately, I had much cancer in my spine. It was not putting out PSMA, so
Yeah.
we were having dueling battles, and so I basically quit Pluvicto in December in order to move to, at that time, etoposide and carboplatin to treat the tumors on my spine. And in the meantime, it's been 6 months almost, and my tumors on my pelvis and the rest of my hip area really took off, and now we're back to focus mostly on chemo, but this time we've switched over to carbo and cabazitaxel. Try to hit both fronts, if you will.
Right. Jim Barnes, you're in the middle of it, aren't you? Aren't you in the middle of Pluvicto?
Absolutely. I had my 5th treatment yesterday morning. So, and I've been faring fairly well. I mean, I've had some fatigue and dry mouth and dry eye and um, some abdominal discomfort and nausea, but generally speaking, I'm tolerating it pretty well. They told me they reviewed my scans yesterday because I was asking. I really wasn't getting any feedback on the efficacy of the treatment. And they said that and he went back and he reviewed it and said the 2 lesions on my back and L4 in my sacrum have turned into sclerotic lesions, which is a good development. And then the lesions on my left acetabulum and iceal is have those tumor sizes have reduced significantly since the beginning of the year. So I didn't see the scans myself, but that's what the nuclear medicine doc came back and reported to me. So on the negative side, my PSA has bounced all around from undetectable. Now it's back. The last time I had it tested was 2.5. So my PSA is bouncing around, and most recently it's a little bit higher than it had been.
So what is it? Did you say most recently 2.25?
2.5.
2.5.
Yeah.
Let me come back to George. George, what is your PSA right now since you've been on the apalutamide and the Zoladex?
Well, I started out at 1200 18 months ago, and then it got as low as 13 in December of 22, and now it's risen to 131. So they
Okay.
said, okay, the apalutamide is done, and they've got to get me on something else.
Right.
And I stay on the Zoladex.
Right. So what questions do you have for some of the guys that have done, or Margie, what questions do you have for some of the guys that have done the treatment?
My question is, after up here, it would be 6 treatments every 6 weeks. And then is he supposed to go into remission? And did anybody go into remission? And what's the best case scenario?
Anybody want to take a shot at that before I jump in and put my 2 cents in?
Well, this gets back to Rick's question about durability. So I personally think that unless a person is not going to make it long enough to get on chemotherapy, I kind of like the idea of Pluvicto first and then chemotherapy, because the Pluvicto is just nicer to be on than chemotherapy.
Mm-hmm.
And we don't want to wreck several months of your life with chemotherapy. The only disadvantage is that if it doesn't work, you've lost a few months, getting possibly more effective treatment in. So I think I kind of like this plan, to tell you the truth. In a person this age, I think it would be great if we did have some gene testing of the tumor, just in case there's a targeted therapy that might be helpful for you. So as far as what might happen, it's possible we've had guys that just didn't respond to Pluvicto, and we've had guys that have had wonderful responses with durability even a year or more. Is that fair to say, guys, for what to expect?
Yeah. So first of all, I think, Margie, you have to see this treatment as a management tool.
Okay.
The likelihood that it's going to give you continuing durable remission is very slim.
Okay.
Can it stay the disease for a while? Probably it may be able to. One question I didn't ask you, but I know in this trial they require, they do a comparison of your your lesions, how many express PSMA versus how many do not. Do you know in George's case what that comparison revealed?
No.
So I think you need to ask your doc, because in this trial, it only requires that 50% of your lesions express PSMA. Okay. Now, you can have the situation like Mike Yancey has, where he expresses, some of his lesions express PSMA, but some of them don't. And Mike did great with the lesions that expressed PSMA when he did the Pluvicto, but we still had to deal with the lesions that didn't. And one of the questions I would have before you even started the Pluvicto is what percentage? If you are 80, 90% avid, meaning 80 to 90% of your of your lesions express PSMA, great. But if you're 50-50, I would say, well, maybe we should be doing the chemotherapy first. Because even if we knock out 50%, we've still got another 50% that we're going to have to deal with. And that's why they do the FDG scan and the PSMA scan, and they look at the two together, and they have that exclusion criteria in the trial. And guys, I'm not so smart. I only know about this because I've just been looking at this trial for Nazir, so it's fresh in my mind. But this concordance between PSMA-avid and non-avid is a big issue that I don't think we focus enough on in the United States. They do in Australia. And when we don't focus on it, we come into this situation like we're seeing with Mike, and I suspect with Mark Finn, and I suspect with Al Latimer, where as soon as you stop, your PSA starts to go up again. Why? Because there's a lot of lesions we didn't treat. And so we've got to drill down on that situation. And so for somebody like George, when you go in and see Dr. Nappy, you ask Dr. Nappy, what percentage of my lesions express PSMA, Dr. Nappy?
Okay.
And then decide, and then if it's 50%, you're going to have a discussion with him or with Dr. Kim Chi, with Dr. Chi or somebody. Is this the right trial for me?
Okay.
I think that's a very good modification of my thought that PSMA first is a good idea. So with what Rick said, PSMA first is a good idea, assuming most of your lesions have PSMA expressing prostate cancer on them. And that information should be available now.
George, do you remember them talking about an FDG scan at all?
No.
Okay, so yeah, ask him about that along with the other PSMA questions. But to answer Marge's original question, what are we looking at here? What are the odds of success? I remember a Dr. Eugene Kwan from the Mayo Clinic saying that about 1/3 of patients do poorly on Pluvicto. They don't respond at all. About 1/3 have a fair response, and about 1/3 have an excellent response. So that's just a general overview. Lots of variables figure into that. Just give you an idea.
So, and when we say they have a good response, the durability of that response, Margie, that we've seen, and again, it's anecdotal, it's not that long. It's probably anywhere between, it probably is not more than 18 months to 2 years in the best case. And then what happens is that these people go back and you can do another round. We've got a guy right now who's thinking of doing another round of Pluvicto.
Okay.
And so it's like chemotherapy, where it can be applied again and again. Now, I know that Brad Powers' group, that the Brian McCloskey interviewed 6 or 7 guys, including Mike, and concluded that the durability that he saw was 6.5 months. I would question that durability number, because that was from the time they started to the time they finished treatment. That's not how I would measure durability. I think durability should be measured either by how long it takes for 3 successive increases in your PSA, or comparing your PSA at the start and how long is it till you get to that same point with your PSA again, or looking at radiographic progression-free survival. But I don't think a measure of durability, in my view, is the time we started to the time we stopped. for a whole bunch of reasons. And so I would say that if you get 8 to 12 months out of this treatment, you're doing fairly well, and with a bit of luck, you might get a couple of years. But then you got to look at the next thing.
Okay, so you're saying 8 to 12 months after he's finished his 6 month, his 36 weeks of, or 6 treatments?
Yeah,
You're saying
after
possible?
he's finished. That
Okay,
that would be a good way. That would be a good way, because a lot of the guys that we've seen have done well whilst they've been on the treatment.
yeah.
Um, and then as soon as they stop the treatment, um, the PSA starts to climb. I can think of 3 or 4 people like that.
Okay,
So, you know, and if you're somebody like a Mike Yancey who has disease that isn't responding to the treatment, then yeah, I mean, your PSA is still going to be driven during the time that the cells that are responding are getting killed off.
okay.
So can we talk to Nazir? Put on your microphone there, Mr. Ahmed. Are you there?
I'm here.
You're there.
Yes,
So, Nazir, is this helpful to you in terms of learning a little bit about Pluvicto?
I certainly was. And yes, and
And
I want to thank you for giving me the list of the trials that are available for this treatment. And I spoke to my oncologist, and he was very receptive to the idea of joining one of the trials that you recommended. However, he didn't know which arm I would be assigned to.
right,
So therefore, he's waiting for an answer from me, and I'm waiting for an answer from you. So that's where the matter ended. Anyway, if he felt if you couldn't get into this trial, then I could pursue the other options, which were 2 places, one in Vancouver and one in Montreal. The Montreal one wants $27,100 per injection, and the Vancouver wanted $24,000 per injection.
right,
And so that 6 times that is 164 in one case, and in the other case, $144,000.
right.
So I'm waiting for a response. No, Dr. Levesque is waiting for a response from me so that he can work on that. And I'm waiting for a response from the 2 sites that will be able to
Well,
assist me.
don't you can't get ahead of yourself here. Again, as we said to you, the first thing you've got to make sure is that you're concordant. There's this discussion that all of your lesions carry PSMA.
Mhm.
Because if they don't, you're going to spend all this money, or you're going to go into the trial and it's not going to help you. So my
Yes,
suggestion, if I was you, is I'd enter for the trial. In order
yes.
to enter for the trial, they've got to do a PSMA scan and an FDG scan, because otherwise they cannot attest that you have less than 50%
Mhm.
non-avid. So they've got to go through these tests. So I would say you go through, you say, yes, I want to go into the trial. You get the answer, and then we can decide whether it's a good trial for you. And
Yes.
then the other thing we can do is wait and see if you get assigned to the Pluvicto arm, which George was lucky enough to get assigned to the Pluvicto arm, the lutetium 617 PSMA arm. If you're
And
not,
yes.
go
Yes,
ahead.
go ahead, please.
I'm saying
I'd like
if
to
you're not,
know
then you
I'd like to
will.
know how did he accomplish that?
How do they? Well, that's a random. That's random.
Random.
That supposedly they put your name in the hat and they
Yes.
pick it out, and number 1 goes in the number 1 goes to Pluvicto, and number 2 goes to chemo, and number 3 goes back to Pluvicto. I don't know how they do it, but they do it on a random basis. But
Yes.
but we don't want to get to that point. First of all, we want to make sure that Pluvicto is a good treatment for you, especially if you're thinking of paying for it privately.
Yes. Now the other question is that Mark brought up, it doesn't treat the bone lesions.
Does it what?
The bone lesion, it does not uh, treat them.
Well,
Pluvicto.
this is what I just said to you, Nazir.
Mhm.
It 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 treats the lesions that have this PSMA protein on the cell,
Okay.
and we have to test to see how many of your lesions have the PSMA protein.
Okay.
That's why we've got to do the PSMA test.
Okay.
So we check to see how many of the lesions it shows
Mhm.
and how many it doesn't show.
Oh, I
And then
see.
we can make the decision. The first thing we've got to do is you tell them, yes, doctor, I want to participate in the trial.
Mhm.
And then you tell him we need to do the PSMA test and the FDG test to
Yes.
see how concordant I am.
Okay. I will do that.
Do you understand what I'm trying to explain to
Yes.
you?
Yes. I do.
Okay. So that's the first step. And then we can worry about what's the right treatment.
Okay.
The second step is to find out which arm they put you in. If they put you in the docetaxel arm, then we can talk about what we're going to do. But we've got to go step by step here. George has done this already, and they've already said, George, we're putting you in the Pluvicto arm, but you're behind George.
Yes. Now, let me see what happens. I'll ask my oncologist for the 2 tests, and let's see
Well,
what that.
I think what you say to the oncologist,
Mhm.
Nazir, is you want to enter the trial,
Yes.
and we need to do the tests.
Okay.
I want to enter the trial. We need to see if I'm concordant. We need to see if I meet this exclusion criteria, if I fail this exclusion criteria.
Okay. I will. He's waiting for an answer from me now. I know I can give him an answer.
Okay?
Okay. Thank you.
Okay. But the answer is let's yes, I want to proceed.
Mm.
Let's go ahead and do these PSMA and FDG tests to see where I'm at.
Okay.
Okay?
All right. Thank you.
We've got to I want to move on so that we can get to all the other people who have questions. Anybody
Rick,
else
may
have
I?
any?
It's
Yes,
John. May I just say something before we move on?
of
I
course.
the new people are appreciate that you have described the difference between the brand name, the U.S. brand name Pluvicto, and its generic name. But I wanted to point out that to make things even more complicated, they have reassigned a new generic name to lutetium 177 PSMA, and it's just as well that we all get familiar with it. Um, it's lutetium vipavotide tetrazetan, and if you want to know more about that, Ben has it right down to a fine point and can explain everything. So there's a new generic name in this country for lutetium.
Stick it in
Okay,
the chat, John. Please, please.
Okay.
yeah,
Ben, are you
somebody.
here?
Yeah, I could put it in.
Would you mind doing it? Because I'll probably blow the spelling.
Right, right. So even more, that's why we want to call it Pluvicto, because it's shorter and it's easier. Okay. Rick Dietrich, did you want to update us on where you are, and do you have any questions about moving to the next phase?
Yes. So it's been 6 years since I got the stage 4 cancer diagnosis, and the hormone therapy has worked famously well for 6 years. But it's worn out its welcome, and now I have unacceptably rising PSA. And so I had a PSMA PET scan, even though I've been keeping up with all the bone scans and the internal CT scans, even an MRI. And I'm in great health. I feel fabulous. I don't have any pain. I don't have anything, but I have some badass cancer. And the PSMA showed definite active cancer in a T9 vertebrae, which actually had problems before, but we got rid of it because the hormone therapy worked. And now it's back. And then in my left hip femur area, I don't have pain, but pretty bright red on the scan. So those are my two places where I don't want anything to go wrong. If this vertebrae weakens so much and I don't do anything to slow my PSA rising up, the cancer is going to weaken the vertebrae. I'll be outside gardening or lifting something. If that thing breaks, I'm doomed. And I don't want my left hip muscle, I mean bone, to fracture or break. So I've done tons of talking to oncologists, got second opinions, and it's really looking like, come on, you you got to do the doxy because it's going to put a dead stop to this. You're in great health. You're going to tolerate it well, statistically speaking, and I feel like I've come around full circle and realized I don't have any other options. I do have located a GU at Huntsman who originally helped me and got me on Lupron right off the bat because I was in the multi hundreds when they found my cancer. And it worked so good, and I was with them for years. But now I'm with a smaller cancer center in Wyoming, but they're good people. And I didn't trust everything they said. They encouraged me to get other opinions. I did. And pretty much everybody has told me, well, your vertebrae has some bad stuff going on there. And if that thing goes into your spinal column or it weakens it and it cracks, there isn't much
Right.
anybody's going to be able to do to
So
help you.
do,
So,
do you have questions for any of the guys in the group?
yes, I want to know. I'm getting ready to start the doxy, and I wondered what you guys thought about what their regimen is for me. They want to start me right out at 75, but they'll back it off and cut it by 50% if I don't tolerate it well. But they want me to start it, and the day before my infusion, they want me to take the dexamethasone, Dexy, and then I do my chemo infusion, and the day after the Dexy, I take. What do you think about this Dexy stuff?
Who would like to? That is the protocol. Who would like to talk to Rick about starting out on chemotherapy? We've got a lot of experience in here.
I mean, I
This is
kind of
Mike
have a
Yancey. I'm
thought.
just make a comment on that because
Go ahead, Mike.
they started me out when I did chemo. They always gave me 10 milligram of Dexy, and that kept me awake for weeks. And so I've convinced my doctor to take me down to 2 milligrams each time I get chemo, and I have no side effects whatsoever. So that's helped me sleep, and resolved a lot of the other issues for me by lowering it. And of course, the doctor will admit that little amount of dexamethasone is almost worthless, but that's what we're doing.
Very good. Very good. Another question I have
Hold
is
on, hold on, hold on. Who else would like to respond to that? There was more than one. Go ahead, Dr. John.
I just want to make sure that you don't have a BRCA mutation.
No, no.
No, okay, thank you.
I would just like to mention, so they gave me Dex day before, day of, right before the infusion. They gave me a big dose as well as Benadryl, and then day after. So you feel pretty good for 3 days. You don't sleep great, and then it kind of hits you. The other thing I would suggest is ask them about Neulasta, because your white count is going to go down after chemo, and I didn't get that the first time, and I ended up neutropenic. Fortunately, didn't get sick, but afterwards, I got that. And if you do take that, you want to take it with Claritin the day of and the next couple of days. That helps reduce bone pain.
So I said no very quickly to Dr. John. If I remember, you did your germline tests and you didn't have anything inherited, but we did recommend that you get your tumor analyzed. Are they doing that, Rick?
oh yes, years ago the tumor that they found one tumor by my spine. They cut it out, they got rid of it, and everything was fine and dandy. And they've 2 times they've put
We'll have a little more.
everything through tests, and nothing came up helpful to me.
Okay. Have they reanalyzed? What's your current PSA?
60.
Okay. Have they reanalyzed your genomics right now? Have they done it before you start the docetaxel? Because we did discuss this.
Well, they've run samples from blood and from tumor to through Tempest.
Okay.
And I asked them how did anything come out that would be constructive, and they said no.
Okay.
And that's what I've got to go.
Okay. I would suggest you get a copy of those reports, and we'd be happy to take a look at them. But make sure you have copies of that Tempest report, both for tissue and for blood, in your files. Okay, next question.
So, of all you guys who've done the Taxotere, did any of you stop halfway through? Did any of you lower your dose because it was intolerable? Did any of you go for that run to the hospital if you have a 100-degree temperature because they're going to and fill you up with antibiotics? I've heard some horror stories about the antibiotic thing if you go to the hospital. I've talked to several guys who wish they hadn't done that.
Okay, let me stop you. We'll start with Dennis Correa, who beat me by putting his hand up because I was going to come to him first anyway. Go ahead, Dennis.
Yeah, it's a very similar situation. I guess I had Gleason 9 and stage 4, and went through the docetaxel chemo, and I got about halfway through the regime and ended up with low white blood neutropenia, and ended up with multiple blood clots in the lung, and I was hospitalized for about a week. And after that, when we started on a reduced dose of the docetaxel, and they added the day after shot that Bob was talking about.
Right.
to keep the white blood cells up, and fully recover from all of that. Still have pretty good results ongoing. So yeah, you could have an upset, but I think they've changed the way they do a lot of the stuff today. But the other question I have for you, it sounds like you only had 2 lesions to address, and I wonder why you offer radiation first.
Well, I did have, when they found me, I was well advanced with the metastasis through my bones. I just had, I totally have never had any soft tissue invasion from the cancer. All of my internal organs are working perfectly. I have great blood tests. Everything is in the bones. And a little spit spot here on a rib, a little thing on my scapula. But really, the big ticket items are that vertebrae and that hip joint.
Right.
Two
So
terrible places.
to answer the question, Dennis, there are multiple lesions, but Rick's only telling us about the big ticket items.
Yes.
Well, that's similar to again what I did, Rick. After I started to have my recurrence and got the PSMA scan and everything, and PET CT scan, and got information like that. There are a lot of little things, but I had a couple of primary tumors, and I had those radiated, and with hopefully good success with that. So
Right. Right.
you don't
So
have to do them all. You hit the main ones, yeah.
right. So let's see where we go. And to answer your question, see how you tolerate it. Dr. Sartor has made the point many times in over the last year or 2 years that he likes to give the docetaxel he finds it's better tolerated on a 2-week cycle and a slightly smaller dose. We've had people who have even done a 1-week cycle and an even smaller dose. But it really depends on how you tolerate it. There's nothing wrong with changing it, but you've got to have savvy enough doctors to recognize that if you're not tolerating it well, that they should be lowering the dose and giving it to you more often.
So the whole idea of maybe zapping that vertebrae that's got the disease going on in it with radiation, that's been totally dismissed by all the radiologists I've talked to, and they said it's much too dangerous. It could affect your spinal column and other organs nearby. It's just not it's not going to happen.
So we've really got to move on because I'm keeping an eye on time. We've still got a few guys to get around, but come back in next week. Build up your questions for next week. We've got the answers. We got the guys who have the knowledge in here, and if you need more, we'll match you up one-on-one. I got a couple of people I got my eye on there, and that I know you can talk to, and they'll be happy to help you as you get into the dose attacks, or Rick.
Thanks.
Okay, we are going to talk quickly to Steve Schuler. I think that's a pretty quick one, if I'm not mistaken. Steve, we can't. Your microphone is on, but we can't hear you, which probably means the right microphone isn't selected. Okay, we'll come back to you. I'll come right back to you. Vic, let's go to you. You had a question?
No question, just an update, Rick.
Okay, great.
A little more than 2 years ago, I was diagnosed de novo bone-only metastasis, stage 4 Gleason 910, and right about that time, the Peace 1 study results were released, and my MO got me pointed towards triplet therapy right away. And I'm really glad that he did, because I had diagnosis. I had a CT scan, and as one doc put it, my skeleton lit up like a Christmas tree. Diffuse, widespread metastasis, and still bone only. And So I haven't had a CT scan since then. It's been, or no, I did. I had a CT scan right after I completed the docetaxel rounds. About a month after I completed docetaxel, they did another CT scan. Didn't show any change. So that was, that was about 18 months ago. Recently had a hip problem. I went to the orthopedic doctor. She was wise enough to look over my situation. Didn't want to, count on a cortisone injection getting the job done till I had another CT scan of the pelvic area. And so had that done. And the results from that, from the radiologist, were, sorry, pulling them up here. Marked improvement in osteometastasis about the right hip without pathological fractures or stress reaction. And so that was, pretty nice to see. And then when the orthopedic showed me the hip scan, definitely the lesions had regressed significantly around the
Wow.
hip area in the femur. And so I chalked this up to triplet therapy early on after diagnosis. I could add something about also my bone density was done right before I started chemo, and that was in the mean of near to a young adult. And I just had that done a few weeks ago, and it's pretty much the same. So glad for that too. But I've only been on this therapy for a couple years, so I'm a newbie for sure. But
So,
I think it's great news. I'm hoping I get the kind of response that Rick's getting and get at least 6 years out of this triplet therapy before I have to go forward with something different.
so are you still on? You're still on the abiraterone and the LHRH?
Right, the Eligard and abiraterone are my still,
Okay.
continuing on with that after completing the docetaxel. Yeah. And
Okay.
working good. I've been undetectable on the PSA, bouncing around between less than 0.01 and either 0.02 or 0.03, but mostly less than 0.01. And no pain.
So I was reading just earlier on today about the ADREAM trial, which Dr. Atish Chowdhury, who we know quite well, is conducting, which is sort of more formally looking at intermittent hormone therapy in holidays. And, it's really up to you, but there comes a time when it's reasonable to raise that in discussion. Should I go off for a while? And you have to decide when that is. But I don't think it's an unreason, with success like you're enjoying. I don't think it's an unreasonable discussion to have with your doc. Anybody want to comment on this successful triplet therapy for Vic?
Well, Vic, you can't argue with success, so keep doing what you're doing. Now, how are you tolerating the hormonal therapy?
It's fatigue is great. My biggest worry about that is, what's it doing to my muscle mass and my bone density? And of course, it doesn't seem like it's had much effect on bone density. And also the CT scan they did showed that there was no, wasting of the muscle mass around the hip either. So those are my main concerns. I can handle the fatigue as long as it's not.
Have you been exercising?
I get up and walk around as much as I can, but the reason I went out and got myself some hiking poles so I could get more steps in and go further, and that's when the hip started acting up. So I think I may have got bursitis. I don't know, but I just got a shot of cortisone. That's starting to take effect already. So I hope to get back out into everything. Maybe some PT going for that.
What about Xgeva? Are you taking that?
No, my bone density doesn't seem to, indicate that that would be
It's not needed?
uh,
Okay.
yeah. I mean, it's still in the young adult mean, for bone density.
No,
Yeah, so
I think when it comes to exercise, there are other alternatives, and it really is so important. I mean, an exercise bike, a reclining bike, a rowing machine. I mean, something, but
Yeah,
that's what's going to help you with the fatigue.
yeah. No, I definitely plan to jump back on the I should say, as soon as this hip, pain, subsides enough.
Right.
Now that I've had a cortisone shot for it.
Okay.
So,
I didn't know
yeah.
you were an erger. We can
Oh,
erg.
yeah.
We
I
can
was a
erg together.
okay. Sure.
Okay.
Yeah, I was a sculler for a few years, and
Oh, were
I
you?
oh yeah, yeah, and
Oh, we
it
never
was a lot.
talked about that.
Yeah,
I've got my skull sitting right outside the door, except that with
yeah,
106 degrees, it's a little hot to take it on the water right now.
yeah. That's the time to be indoors with the erg for sure. Okay. Yeah, I would add one thing about if I was looking to re-challenge with docetaxel, I would definitely be talking to my doc about reduced dose and possibly more frequent, every 2 weeks or every week with a reduced dose, just because I'm, 70 years old and perhaps by the time I get ready for a re-challenge, that might be the best way for me to go. I'd certainly want to have that option. About 3 infusions in, I had a pretty nasty reaction, probably more to my not paying attention to what I was eating. Had some severe diarrhea, and that scared me pretty bad. And he let me take a week's vacation, and the next dose he gave me was slightly reduced. And then after that, I just went on and finished all 6. No major problems. My wife kept me on a really good diet the whole time and kept my blood count up really high. I only took uh, Neulasta at the very first part, and I probably didn't really need it then, but I just took it to be on the safe side. And definitely, if you wind up taking Neulasta, you definitely want to take the Claritin. Don't miss that, because I didn't have it when I had my Neulasta, and I had at least one sleepless night with bone pain as a result. And I had Dexa at day before and day of and day after for every infusion. It really never bothered me, and it's, I guess, did the job it was supposed to do.
Okay. You know why your bone density is so good, don't you?
Yeah, I think I do.
I
I
do.
do
It's
weight
'cause
bearing. I do weight bearing exercise every time I get out of the chair. So
well, there you go. I was going to say it's because you're a scholar. That's what it is. That's what I tell everybody. All right, we're gonna keep moving along here. Steve Schuler, can we hear you now? No. So sorry. You can call in. I don't know what's wrong today, but try calling in, going out, coming back, coming on the telephone. I'll try again. Don't worry. Um, Let me make a big circle there. Dr. Bob, you had a couple of questions, and then we're going to go from Dr. Bob. We're going to go to Spencer. So hang in, Spencer. Dr. Bob, what's your question?
Okay, just more of an update. So I'm almost a year from starting chemo. Chemo worked well until it stopped. My PSA has been ticking up since January. So yesterday I had my first PSMA PET scan, which showed more bone lesions than the CTs or bone scans, but nothing in lymph nodes, nothing in soft tissue or organs. So that's a plus. And thanks to Rick, I'm trying to set up for a second read, second opinion. And then today started my first Keytruda infusion, which is a whole lot easier, at least while you're there, than chemo. And hoping not to have too many bad reactions, and hopefully with the biomarkers I have, I'll get some good results, because 3 weeks ago my PSA was 2.22, and yesterday it was 2.73, so it's clicking up pretty good. I think I'm starting to feel some bone pain as well in a couple spots. Hard to say. So that's the end of the update.
Well, it's like the good news and the bad news, this one, isn't it? Because it's great that you're still only showing bone lesions, but you're showing more than a little more than you showed before, right?
Yeah, I mean, they may have been there and just didn't show up because they weren't, sensitive enough to pick them up.
Well, Peter, of course, who isn't on today, is our Keytruda expert. So he's the guy that's going to hold your hand if you have anything weird going on.
Yeah.
I don't know. Anyone else in here has anyone else in here done Pembro at any time? Pembrolizumab or Keytruda? I don't think so. But
Yeah.
we are
Cautious.
keeping our fingers crossed for you. You are in the sweet spot. We know that.
Yeah. I'm cautiously optimistic.
Okay.
I've got a question.
Yes, go ahead, Rick.
So, I'm pretty new to this group, but I've been noticing that there is this common denominator is a lot of you guys have really low PSA. And I know you've been through the ringer and done this and that and all these different drugs, and I'm keeping track of everything. I'm learning a ton. But I just don't understand how a person can have bone pain if they have such a low PSA.
Right.
How
So
does that
let
happen?
me explain. Let me explain. Let me give you a little background that might help you. Prostate cancer is a very, very heterogeneous disease, meaning it's very different in many people. If it presents as we often see it, like it did for you or it did for George Strzok, with very high levels, or for Jerry Pelfrey, or we've had any number of these guys. It's really actually a good thing, because we know that most likely the cancer is driven by adenocarcinoma, and we know it's going to respond well to hormone therapy. The type of prostate cancer that seems to give us the most issues is the prostate cancer that is high Gleason and doesn't express much PSA at the time of diagnosis. So a guy comes into us and says, "Yeah, I just got diagnosed. I'm 4+5, and my PSA is 5, 6." It gives us great concern right at the beginning, because we already know this is going to be a difficult to treat prostate cancer. Some people are already diagnosed metastatic. Some people are not metastatic, but aggressive Gleason scores with low PSA is more common than you'd expect. It's not super common, but we see it a lot, and we see it in this group a lot when people come in, and we know that type of person is less likely to respond well to hormone therapy treatments, which is exactly where Dr. Bob is. Diagnosed a couple of years ago, PSA was never that high Gleason scores. Am I right, Dr. Bob? I'm saying that, but
Yeah, so I was diagnosed April of last year, Gleason 9, PSA 28. And yeah, I mean, I know someone who
metastatic.
I know someone who was metastatic. His PSA was over 10,000, and he's 4 years later, after 2 rounds of chemo, he's down to 0.02.
Well, I'm more like the guy you're describing, Rick. I was metastatic right from to get go with a Gleason 9, but my PSA never even got over 6.
Right. Right. So, like I said, this is a tough disease, and no one's ever typical in this disease. But we do know that for somebody like you, we would hope that you're going to do well on docetaxel. Then, somebody who's been through all the treatment, because we think you're going to respond. I hope that answers your question.
Are you talking to me?
Yes.
Yes, that was very informative, and thanks a lot, Rick. I'm figuring it out. That was very interesting about low PSA, but high degree of intensive PC, and that's the opposite of what I was. And this whole hormone thing it's worked famously on me for 6 years. So I'm ready to move on, but that's very interesting. That explains why I sit here and listen, and I hear all these guys saying, "Yeah, I got a PSA 1.22 or
Right.
1.86."
Now, also remember, Rick, a lot of these guys are telling you that they've already been through some treatment as well.
Yes,
So,
exactly. So
they may have been as low as undetectable, and now their PSA has come back up to this level. So there's always a story. Okay, we're going to try Steve Schuler for the third time. Can we hear you this time, Mr. Schuler? No. Next week. I don't know what's going on. It's got to be something at your end, I hate to say, but we can't hear you. So, when this happens, the best thing to do is to call in. We put the telephone number in early on, but call in on the phone. We can see you. You can call in on the phone at the same time, and that's the best thing to do. If you can get in on the telephone in the next 15 minutes, we'll pick up. Oh, you got to walk. You got to walk away. You got to go. Okay, but the telephone's a good idea. That's why we put that number here. Let me go in and recopy the number from the beginning. Here's the number, just in case you can write it down for future. Here's the number. Copy, paste, and here's the code that you have to put in when they ask you. Copy, paste, and that goes to everybody. And so that's what to do when we have this problem. All right, we're gonna go to Spencer Field. Spencer, you're
Hi.
up.
Okay.
Hi. We can hear you fine.
Oh, that's good. I just let me just give you a little background. I was diagnosed last October, and it's metastatic, a Gleason score of 10, and they didn't do a full biopsy at that time. It was they had tried to do a TERP on me, or my urologist tried to do a TERP and wasn't able to break through on the TERP. So he did a little scraping, and then the biopsy came from that. I've recently had a full biopsy with that was about a month ago, and it still confirmed the PSA, the Gleason score of 10. I've been on the anti-androgen therapy, the leuprolide and abiraterone, for I guess for 6 months now. I just last Friday I had an appointment with the oncologist, and I got my leuprolide injection, my every 3 month leuprolide injection. My PSA was at a high of 22, but they told me that because I was taking finasteride, it was really higher than that. They say that if you're on finasteride, you should double the PSA score. I don't know. I never heard that before, but that's what they said. However, right now, on the last one, under this last appointment with the oncologist, my PSA is down to 2.08, which I guess is pretty good. The symptoms, the pain symptoms have abated quite a bit. I was getting a lot of rectal pain. I was getting a lot of pain in my penis. I cannot urinate. So I've been on a suprapubic catheter for close to 6 months now, and they tried to do my urologist, or a different urologist who is more of a specialist in this type of surgery, tried to do a TERP on me and was unsuccessful, was not able to break through the urethra and the prostate. And the way he explained it to me, he said that the tumors around the prostate are so enlarged that it's really almost obliterated the urethra. And there's not much that they can do. So I guess I'm stuck with the suprapubic catheter, which is not the worst thing in the world. I'm kind of used to it. It's not giving me any pain. So anyway, however, I did have the question I had is I go to a interventional radiologist once a month to get the catheter changed. The last time I went, the guy recommended a prostate artery embolization. And he said that they've been using this to shrink the prostate, and they said that they don't necessarily use it for prostate cancer patients, but they use it for patients that have an natural enlarged prostate.
Right.
And they say it will on the average shrink the prostate 30%.
Right. So let me stop you.
Okay.
A lot of what we're talking about is fine if you don't have prostate cancer.
Right.
Your issue is complicated by the prostate cancer.
Of course.
So the first thing is that I'm not really sure whether, yes, if you're on finasteride or dutasteride, the old form of it, you do double your PSA. Whether that's true when you're also on hormone therapy, I really have no idea. I don't think it would be true any longer once you're on hormone therapy. But if you're not on hormone therapy and you're on one of those drugs for BPH, you can safely double your PSA score. Why? Because it artificially shrinks the prostate. But the issue that you have is not so much the cancer that's in the prostate. It's the cancer. It's well, I shouldn't say that. The issue are the tumors that are surrounding the urethra as the urethra goes through the prostate, right?
Right.
And the embolization is not going to affect the tumors.
Right.
The embolization is going to affect the size of the prostate and reduce the inflammation, but it's not going to get rid of the tumors. Otherwise, we'd all be doing embolizations for the cancer.
Right.
So your interventional radiologist isn't thinking too clearly.
Well, yeah, he doesn't think he's not suggesting it as a treatment for the cancer. He's really suggesting it as a treatment that it might shrink the prostate enough that I can start urinating again.
Yeah, but the problem you just said it is you can't urinate because the urethra's constricted, and the urethra's constricted because there are tumors all the way around it.
Right.
So what are we going to do? We're going to shrink the prostate. It'll just be like a smaller container, shrink wrap around the tumors, right?
Yeah.
I mean, sometimes I think these guys don't think straight because it isn't. I'm not a doc, but if you think about why these things work, I mean, that's my response. I could be totally off base. I'm not a doc, but it sounds.
This makes good sense.
It doesn't sound.
and the radiologist is not he's not a cancer guy. I mean, he's a radiologist.
He
So he's
doesn't have to
talking.
be a cancer doc. I mean, it's Sergio. He doesn't. He's
Yeah,
you got to think this stuff through. I mean, that's my response,
that makes sense.
Spencer. I mean, I don't think. I mean, you can talk to your guy Jeffries or Tester at Jefferson, but he's going to probably laugh and say, "Who gave you that idea?" And you'll say,
Yeah.
"Well, you're interventional radiologist. Why don't you have a word with him over the coffee cart?" I mean,
Well,
that's
actually, I didn't talk to Tester about it, but I talked to the urologist that tried to do the TURP surgery, and I actually had the guy the radiologist call him and have the two of them talk. And when I had my appointment on Friday, I had an appointment with him as well as an appointment with Tester.
so. What
And
do they think about that? Do
pretty
they
much
think it?
pretty much what you said. He said
Right. So
he didn't think it'd be
let's not. I don't want to spin wheels here because this is to
no.
me, it's silly.
No, I just thought that maybe overall shrinking the prostate might have an effect. I know it wouldn't affect the tumors, but
Yeah, you know what it's going to do? It's going to put more pressure on those tumors that are going to clamp down tighter on the urethra. That's what it's going to do. I mean,
well, yeah,
right now they're there. Now we're going to push them even closer against the urethra. Do we
yeah,
want to? No. What we want to do is shrink the tumors so that they release. That's what we want to do. So we want a treatment that's going to shrink. That's going to shrink those tumors. That's why you're taking what you're taking.
right. Well, so far it hasn't very much. I mean, maybe it has. I don't know, but I mean, I know my symptoms have definitely gotten better. I'm definitely not as I was at the beginning. I almost
Okay.
couldn't sit down, but now I can, and I have a lot less discomfort. I don't have any bone pain anymore. Uh, and my energy level has coming is not quite normal yet, but it's way better than it was early. So I believe the therapy is effective, and I'm
Okay.
definitely going to
Let me.
continue.
I want to ask a question on behalf of Steve. And is there anybody else that wants to say anything to Spencer? I've sort of dominated this particular conversation, but I think it's a bit of a wild goose chase. But that's my own opinion. Am I
No,
wrong? Anybody want to? Any of the medics on here want to call me out? Oh, Dr. Bob left. He was feeling fatigue, so he's not here anymore. So, all right, let me just pose the last question, and then and I think we're pretty much done at that point. But Steve's question, and he'd written it to me, is that he tried to get to see Dr. Graff at OSHU, but they're in such confusion at OSHU. OHSU is Oregon Health and Science. It's a very good, fine NCCN cancer care hospital in Portland. But they've had a lot of turnover in their GU med oncs. And we sent Steve to Julie Graff, who we like, and they're not taking new patients for the purpose of second opinions. So the question is, where else could he go? He doesn't really want to mix it up any further in Seattle Cancer Care, UW, Hutch, whatever you care to call it. And we've suggested a name for him at UCSF. I really don't know anywhere else to send him. I mean, there are a couple of people at Swedish that we've worked with before, but they haven't left a huge impression on me. Swedish is a big hospital in Seattle, and so we're just throwing it out to the group. Does anybody have any um, suggestions. I'd say Halaborno, Mr. Schuler. I'd say Halaborno. She's very nice, and she'll give you a good second opinion. And if you have to jump through hoops a little bit, but I would say Halaborno.
What part of California is City of Hope? Is it north or south?
South. Yeah,
Oh,
that's all the way down. That's all the way down in it's east of Los Angeles. So we don't want to send you all the way down there.
no, no.
All right. Russ, did you say you did want time or you didn't want time?
That I did. I just have a question maybe somebody can help me with. In the last couple months, I have developed real problematic peripheral neuropathy in my feet. I've tried gabapentin. I've tried, if I can pronounce this, pregabalin. I'll probably pronounce that wrong. And these are the only two things that were supposed to work. And then I was in the doctor's office talking to somebody sitting there, and the guy said, you got to load up on magnesium. It'll help you. So I started doing some research on magnesium, and I found out there's 3 major types. Does anybody have any suggestions? Is this even worth chasing?
Well, I'm going to go first of all to Dr. John, but I do have another suggestion for something for an easy fix. But Dr. John, you want to talk about the magnesium first? Oh, I think he's looking it up there. I think he's looking it up.
Yeah, go ahead, Rick, while I look it up.
Okay, so whilst John's looking at the magnesium, I'm going to give you the Peter Kafka solution, which he gave to me, which has worked great for me, which is vitamin B6.
I'm taking B6 and 12. Maybe not enough of it.
How much B6 are you taking?
Whatever's in a dropper. I don't know what that is off the top of my head. Is there a volume that I can relate to?
No, I don't know. I mean, I have to go look at my pills. I think there are 100 milligram. I don't know. I'll let you know. But I take. You can take quite a bit. I take right now 1 a day, and they've made. I mean, I still have it, and I have it especially in the winter when it gets cold. But it has definitely been easier since I started taking B6. Definitely.
Just B6.
Yeah, just B6. I take solid B6 tablets.
Okay, these are tablets.
Yeah, I take B6 tablets, which I buy at CVS and or you can sure Walgreens, and I take one of the pills, whatever size they are. I could take 2, but it's been really helpful to me.
Okay, and this is not something that will load up in your system and create problems?
I don't know.
Okay.
But, I always say, like we always say, if you're going to add something, make sure you run it past your GP or whoever it is and make sure it's good for you. But I know that I could take more, and that for me, I'm doing fine on 1 pill a day. John, did you find anything about magnesium?
Well, I found a great thing about magnesium. It says magnesium is abundant in dark chocolate. I'm getting mixed results here. Foundation for Peripheral Neuropathy states that magnesium may help with chemotherapy-related neuropathy, but more research is needed. Another study in nutrients found that people with high magnesium levels had less neuropathy, but then another study in 2013 with magnesium did not show any benefit at all. So I'm getting good mixed results, which means give it a shot.
Okay. In my research, as you were doing there's a glycinamate, an L-threonate, and an oxide that are all available across the counter. And I can't find anything that can help
Well,
me
I,
different?
what I heard John just say, and I think this is what you got to check, is I wonder if there's a difference in I wonder if there's a difference in the peripheral neuropathy that is generated by chemotherapy and the peripheral neuropathy that might be generated from hormone therapy.
Mine
And I
is
don't know
hormone.
the answer to that. Len, do you have any input on that?
Muted, Len.
Sorry, I was muted. So I was looking up connection between B6 and neuropathy, or prevention of neuropathy or treatment. And all I'm finding for the most part is that high doses of B6 can cause peripheral neuropathy.
Right. Yeah, that's true. But low doses are helpful. But
Okay.
the question is what's high and what's low. I mean, it's.
Yeah.
Russ, why don't I look into it, Russ, and I'll write to you, okay?
Okay, appreciate that. I just thought maybe.
Anybody else have any tips for peripheral neuropathy that's worked for them?
The cause is unknown, right?
My understanding is that people who were on the drugs I was on, Lupron and enzalutamide, after you get off of them, there's a 5% chance you're going
Yeah,
to get it. Not right
yeah,
away, and that's what happened to me. I didn't have
right.
this before. About 6, 7 months after I stopped the medications, I started getting tingling in my toes. Now it keeps getting worse and worse.
It might get. That's exactly what happened to me. I was never on a secondary treatment because it wasn't prescribed at the time.
Right.
I was on, but about probably started about 2 years after I came off of the Lupron,
Yeah.
and I've had it ever since, and it's not very nice.
Okay.
But you deal with it. You deal with it. So, um, anyone else have anything they want to input on PNI to on a PN peripheral neuropathy? So, Dr. Jack, we've got 5 minutes, or if you would rather hold off till next week, you're more than welcome.
Well, it's up to you. It's really just an academic question. I wanted to know a little more because I'm very curious why more people are not being treated with BAT. I listened to a webinar and it was very impressive in terms of not only the work that's done at Hopkins, but it's being done all over the world, and they're raving about phenomenal benefits with a greater quality of
Right.
life for people who have castration resistance. And I'm wondering, what you've been talking
Well,
about it all. Yeah, right.
I think I can answer it in one word, which is durability. Um,
Uh-huh.
the big issue, and by the way, Sam Denmead did a webinar that's on our ANCAN site back in 2017. If you Google Denmead, you'll find the webinar he did and the slides that he did for us. So we've been around BAT for a long time.
Yeah, it's all,
I think the big and interestingly enough, it came up in the webinar that Oliver Sartor gave to the power group last week, and he was talking about it. And he thinks it has its uses, and I got up and I said, well, how durable is it? And he said, well, maybe you get 8 months. And I think the big issue with BAT is that yes, it can work, but maybe it gives you about 8 months from the time that you start and go through however many cycles and then finish and then wait to see what happens, what it does to your PSA. And what we've typically seen is that it cannot work at all. Most people get less than 12 months. I think the best we've seen is about 12 months. So I think it's a durability issue. Can you
Rick,
do it again? I'm not sure. I mean, we've had some people, I think, maybe try it a second time. The person to really drill down on that with would be Ken Anderson, because I think he's really looked more at it, harder at it than most. Mike Yancey's thinking about BAT or doing BAT right now. I don't know how much research he's done behind, but we can, if you're interested, let me know. Jim Barnes, you wanted to make a comment?
So I was just going to say, I was listening to Dr. Sator last week on that webinar as well. And I think, didn't he say that he's comfortable with that on low metastatic volume as opposed to higher metastatic volume? So that's something to consider as well.
yeah,
Yeah.
he did say
Whether or
that.
not you agree with that.
He said if with high volume metastatic disease, he has seen that therapy accelerate progression
Yeah.
of the disease. Also, I've heard several oncologists say that if you have a high copy number of the androgen receptor, you will do better on that therapy, which makes sense.
So there you go, Dr. Jack.
All right, you want to say a little bit about the saturation point with testosterone.
That we're getting above my pay scale as
Oh,
to
okay, all right. Well,
what that is, and I don't know. I mean,
the threshold of 250. If you go above it, it doesn't make much of a difference in terms of. Yeah.
Yes.
Yeah.
That's what I've heard. That's yes. That from that standpoint, yeah. I mean that it doesn't once you get to about 250, it doesn't matter whether you're at 250 or 2500.
Exactly.
That's what we've heard that.
It's something that was
right, Len.
Yep.
Comment.
Yeah, that's true. But I suspect that if you have a high copy number of the AR, then it doesn't get saturated quite so quickly, and that's why the high dose testosterone in the BAT therapy could be effective.
I was just wondering about this because I brought a high testosterone for 20 years, and I don't know if it helped me or hurt me, whatever. I was wondering. I was always concerned about it. And Scardino said, "Don't worry about it." He kept talking about saturation points, and it was like 700, 800, and then even now with the darolutamide, it stayed up there pretty high. And now that I'm on Orgovix, I'm sure it's going to be down to nothing. But I just wanted to know from an academic point of view what your thoughts were about BAT, saturation points, things like that, because I'm starting to, appreciate it in relation to my own testosterone.
You flatter me by saying an academic standpoint, Dr. Jack. I don't. Mine isn't so academic, but maybe Len's and Ben's and Dr. John's may be more academic.
You know a lot. You know a lot of stuff, and you're teaching me a great deal. So I appreciate your input.
All right, guys, we got to close out. Otherwise, the MS people are going to run into this room and chase us out. We've been very lucky. We haven't seen one MS person in here. I don't think. Jay, you came in late. I'm not sure which Jay it is, but welcome and hello, Jay.
Hi, is this supposed to have started at 8 o'clock?
No. Our
Oh,
Tuesday meetings start at 6 o'clock Eastern.
okay.
Our Monday meetings start at 8 o'clock Eastern. Okay.
Okay, got it.
Okay. Mondays 8 o'clock. Tuesdays 6 o'clock. Okay.
I'll try to remember that.
Okay. Come back next week at 8 o'clock, and we'll take care of you. Okay.
Okay, sounds great.
Rick,
All right.
could I make one
Yes.
comment?
Sorry?
Rick, may I make a comment?
Yes, go ahead.
You know,
Yes,
one
sir.
that I have tried to do, and the doctors have always said, keep getting exercise. So, I play golf. I walk the golf course 4 times a week and then bike 25 miles a day on the off days. And this winter I skied 75 days. And then I just got back from a 700-kilometer bike ride in Italy. So I'm really trying to keep exercising and keep doing things. I know maybe it's a bit risky because I don't want to break a bone, but still I'm doing it.
So,
How old
George,
are you, George?
How old
86.
are you?
Holy
80,
smokes.
86. God bless you, George. You will go,
God bless you.
I hope you come in next week, and I'm going to come to you at the beginning of the meeting or right after our new people, and you're going to say that again because we would like to discuss that. And we are huge endorsers of exercise, and that is amazing. We've got to go because I did see my MS moderator pop onto the screen, which means we've got to shut this room and start the new one. But
Good night.
that is fantastic, George. We love it. I wish you could catch fish as well as you exercise, though. There's a word out there that you didn't catch too many fish when you went down to that boat of Neil's.
Well, my wife is a fast walker. So when we're on a golf course, she has a cattle prod. She keeps poking me to go move faster.
Okay, we'll speak to you. Come back next week, and we hope you got a lot out of this. Come back next week, and we'll talk more about your amazing exercise. God bless you. Good night,
Okay.
everybody.
Right. Thank you very much.
Night.
Thank you.